Okay, so this session is going to be a year in interventional cardiology, and we'll discuss what's the latest in intervention, some structural, and some case to illustrate this session. So we have two speakers, both from UK, Andreas Baumbach and Dr. Hani Ateba. So we're going to start, and I need to my panelists, where are they? موسى أكبر مش موجود. عبد المجيد زبيدي. عبد المجيد زبيدي. أحمد الجندي. فؤاد سعيد وهاني راقي. So I need the panelists to be here at least يعني before we start with the speaker. The speaker ready, panelist not here. موسى أكبر. Come, you'll be. موسى أكبر, come خلاص. So we're going to start with Andreas Baumbach, and he will take us to top 10 news in interventional cardiology in year 2022, including new trials, guidelines 2021, 2022, and all of you know Andreas. I don't need to introduce him. He's chair of device innovation, consultant interventional cardiologist, and he is also board of directors of largest intervention congress, EuroPCR, and has been here many years, many times. So welcome, and take us through the top 10, please.
Thank you, Abdullah. Yes, welcome, and thanks again for the invitation. It's absolutely lovely to be here. You know, I've been involved with Gulf PCR and been to Dubai many times, but the first time in this meeting, and I must congratulate you. You've set up a really a wonderful 3 days. So you've asked me about the top 10 news in intervention, and this is, I thank you for the task, but it's always a bit of a struggle to go through and find the really interesting things. So first question, of course, is what's news? And in the context of this talk, clinical trials potentially changing our practice. I was looking for those clinical trials with no impact, but confirmation of current practice. Guidelines, we'll see about that. Definitely no drugs, no glyphosines today. We're interventional cardiologists, although they are important, I accept that. And then some local news from London at the end of my talk. Number one, for me, was protected TAVR. Presented at TCT 22 and simultaneously published in the New England Journal of Medicine, first author Samir Kapadia from the Cleveland Clinic. And why did I choose this? Because it's really the first appropriately sized randomized controlled trial to answer the question, does embolic protection with the Sentinel device, and that's important, reduce stroke? And they put 3,000 patients in thinking that would answer the question. The answer looks like this. And the answer is yes and no, maybe, if you look at the comments. Yes, numerically there's a reduction, and definitely there's a reduction in disabling stroke, but statistically there is no reduction of any stroke. So what we have is no significant reduction in all periprocedural stroke, disabling strokes 0.5% versus 1.3%. And that leads to this sentence in the conclusion in the New England Journal, but on the basis of the 95% confidence interval around this outcome, the results may not rule out a benefit of embolic protection during TAVR. So it remains open, and maybe the additional 7,000 patients from the British Heart Foundation PROTECT will clarify the situation. So the UK to the rescue. We're working on it, and we're halfway there with this BHF PROTECT trial in the United Kingdom. Second, another British revived BCIS 2. I'm sure you heard about it. It was presented at the ESC, and it was published in the New England this year. And first author is Divaka Pereira from Tommy's in London. We participated. Why did I choose this one? Well, it is a big randomized controlled trial, and it wants to answer the important question, for all of us important: does PCI improve event-free survival and left ventricular function in ischemic LV dysfunction? 700 patients, and we enrolled at Barts. These were difficult patients, multivessel disease, reduced LV function less than 35%, and it was PCI versus optimal medical therapy. And the answer here, very disappointingly, is an absolute not really. And this is puzzling because there wasn't even a subgroup with a clear benefit from PCI. You can see on the right-hand side the usual graph, PCI better towards the left, optimal medical therapy better towards the right, and we go through age, jeopardy score, ejection fraction, diabetes, NUHA classes, atrial fibrillation, left mains, and even the NTN-proBNP classification. So nothing there. There were very high event rates, 37, 38% of death or hospitalization within those 2 years. Quality of life improved a little bit with PCI, but then settled. LV improvement in both groups. And PCI completion, complete revascularization in 71%, so not bad. There was no confirmation of viability ahead of it, but we know from Stitch that that doesn't really work either, to have MRI confirmation of viability before you go on and enroll or do PCI or revasc. So my big statement here is I'm puzzled. I don't understand it, and I'm not clear what to do with the next patient that comes along with multivessel disease, reduced LV function, no angina to treat, but, you know, do we still stent them? I don't know. Moving on. Bypass CTCA. And you may have seen that one. Dr. Dan Jones is one of my colleagues at Barts in London, and he presented this as a late breaker at TCT 22, and it's as of yet unpublished, but it is really interesting. So I presented, of course, because I promote a big study out of my hospital, but also because it answers an important practical question. In patients with prior bypass surgery, and that's a lot of them, with chest pain requiring an angiogram, does a CT coronary angiography reduce procedure time, and does it prevent complication? What do you think? I don't know what your practice is. We tested that 688 patients in a single center approach at Barts, and the answer is an absolute clear yes. And the results are more than surprising, really. I think if you look at the details, I sat on the DSMB, I saw them all coming along. It's very clear. CTCA, prior to a planned angiogram, leads to less procedure time because you know where the grafts are. You sometimes don't need to even look for the IMA, so you can go right radial. All sorts of things come together. You don't need to chase occluded grafts because you know they're blocked. Less procedure time, that's clear, and by a big margin. Less contrast-induced nephropathies because you use less contrast. And we know most of the contrast-induced nephropathies in these trials are not clinically relevant, but I've asked Dan, and what we see is we do see less prolonged inhibition of renal function. So there is something more than a signal. And less vascular complication by a big margin. And again, that might come by the reduced use of femoral access, but a lot of things come together. It's clear you reduce the complication rate. So even the patients are more satisfied because it all goes quicker. So, in conclusion, next time you have a patient coming in with previous bypass surgery and chest pain requiring an angiogram, consider doing a CT coronary angiogram before the planned invasive angiography. I'm sure that'll make it into the guidelines somehow. Right, what's next? I like that one. Did you follow that story? Simplicity, HTN3. So this was a really big thing at TCT 2022, and it was published in The Lancet at the same time, this year. Deepak Bhatt, the principal investigator of Simplicity, HTN3, gave this talk, Long-Term Outcomes Following Catheter-Based Renal Denervation in Patients with Uncontrolled Hypertension. Final follow-up of the Simplicity HTN3 study. It's a bit like this, right? It's like Phoenix from the ashes. Because if you remember 2014, we thought this was dead. This was the original trial, very well published in the New England Journal of Medicine, where they clearly showed that after 6 months, renal denervation did not result in a relevant or significant reduction in blood pressure. And there was a lot of speculation where this would lead. And where is he? Carlo Di Mario said, Simplicity HTN3, the death knell for renal denervation in hypertension, which he then thought it was. So, what's new? Well, they followed these patients further on, and they looked at 24 months, 36 months, 48 months, and they presented this as the results and published it in The Lancet, as I said. But of course there are comments and there's criticism, and you have to be aware that this is not the original randomized blinded cohort. They're all unblinded now. There's a lot of crossovers, and they did some mathematics to account for the crossovers. So not everybody is convinced, and we need more evidence, comes more than once. Renal denervation is doing something, to what extent, and so on. That might be slightly different when more definitive trials come out. So not entirely convinced, but interesting. Have you heard of Universal? So that's another one that was presented at TCT, published in JAMA Cardiology. Here, Sanjit Jolly, first author. And that, of course, was the question in a randomized trial, does routine ultrasound guidance for femoral access reduce complications? It's a big trial, 621, that's why I've chosen it. And the answer, what do you guess?
No, it was a negative.
Not really. There's no reduction in bleeding. There is a reduced access to the venous system, so accidental venopuncture. You get it right first time a bit more often, but despite the fact that this was a negative trial, they managed to make it positive by bringing in a new meta-analysis where all of a sudden ultrasound, of course, wins against blind puncture. So that was Universal. Slowly going through here. Have you heard of DISCO? DISCO Radial, presented at Euro 22, published in JACC Intervention. First author and presenter was Adel Armenian from Belgium. And of course, for a while, we all thought that the distal radial access is a fantastic alternative, and not only is it easy to do and good for the left side, it potentially is also superior to transradial. So the question here is about superiority to our standard transradial access. On the right side, you see what they did. They did everything right. Coagulation, spasmolytic treatment, everything was the same in both groups. And the clear answer, however, when you randomize, there is no real superiority in this distal access. Actually, there's no difference in overall bleeding and vascular complications. Patent hemostasis was achieved in 94.4 in the transradial group. There's higher crossovers with distal radial artery in 7.4 versus 3.5. So it doesn't really stack up, and certainly no drive to make this the preferred route for routine intervention. Now, I bet you haven't heard of that one. Explant to redo TAVR. And it took me a while to put that on the list, but actually I think it's worth a notice. It was presented at TVT by Goyle, and this data set, the new one, is not yet published, but there is an old one. This is a registry, and there is Vinny Bapat published the surgical results from the explant TAVR registry. Now, why is this important? It's large. It's a large multinational registry. They have 354 patients with failed TAVR. So patients that required something new. And explanting is a new procedure. And the reason I looked at it is because I came across that recently when I gave a talk about lifetime management of patients. You know, patients that have a long life expectancy, what do we do with the first intervention? Is it a surgical valve or a TAVI? And I came across this from our friend Giuseppe Tarantini, where he looks into the different options for first, second, and third intervention. Where can I see that here? Where's my pointer? I can't see the pointer, sorry. But you see that in the second block there, all of a sudden, he brings in explant, the TAVR, and put a surgical valve in as an option. And I hadn't heard of that before, and I wondered, what's the risk of that? Is that really something we should be discussing? Now, at least this explant to redo registry sheds a light on it. It looks at the results between redo TAVR and explant TAVR. So a comparison. And redo TAVR are older and have a higher risk. As expected, it's not randomized. But if you look at the results, the in-hospital for TAVR explant, the in-hospital mortality is 11%, the 30-day is 14, 1 year 35. It's a sick population, but the in-hospital mortality is high. The stroke rates are comparable to redo. But the surgical risk here is not negligible. And I'm sure you would agree that this doesn't look like a routine step in a multi-step long lifetime management process for a patient. Right, guidelines. Because I put it in the title, I looked at guidelines, but actually 2022 is not the year of the guidelines, at least for us. The only thing I could find was maybe the new heart failure guidelines in the US. They have top 10 take-home messages, and 9 of them have to do with glyphosins, so I don't bring that up. There's really nothing new regarding revascularization, and they said they would wait for the revived BCIS2 study, which you now have heard the results of, so they will have to rewrite their guidelines, or at least put in that revascularization in heart failure patients with multivessel disease does not reduce mortality. Coming to number 8 of 10, Eurointervention Journal. I always bring up the best paper in Eurointervention. I've asked Davide Capodano And he said the most cited article in Eurointervention, believe it or not, in 2022 was the 21 Bifurcation Club report. And the reason I bring it up, not to go into any details, or not because they have massively new things to report, but I can't help but marvel at the 22 edition, and I want to bring it up here, the 16th expert consensus, because you've never seen a document so clear and so step by step for all the different situations with beautiful illustrations. If you want to know about bifurcations, these two papers are highly recommended. Everything new is in there. My personal practical highlight this year was this TAVI for pure AR. Really made a difference. There was a presentation at Euro. It's not yet published. And because that's the topic of my next talk, I will talk about that for much longer after this one. And you'll hear all the results. And then coming to a nice end here, some local news from London. You might have heard, but I just want to bring to your attention that Cleveland Clinic London is now open, a 184-bed hospital just behind Buckingham Palace. It's a fully functional hospital. I'm part of the team together with Bernard Prendergast, Simon Redwood, and plenty of other people from London that you know. We've got an acute admissions unit which sets us apart from all the other private practice that is going on in London. We've got a really beautiful cardiac team, and I'll invite you to have a go around if you're ever in London. It's a beautiful hospital. And on that note, I thank you and invite questions.
Excellent. Thank you very much. Very concise, I think, and very informative. So we have 10 trials or some guidelines with it. And so for me, one negative is revised. BSS2 is great for me, and bypass CTCA for reason which mentioned. We'll start with Abdulmajid. Which one is, and the reason?
You know, the first study, which is the protected TAVR, my question, do you still, Andreas, think there is a role for protection devices still? I mean, despite that trial, still, I see my colleagues in the practice, they didn't change, and they have some concerns on regarding that trial. So where do you see us heading in terms of protecting the brain during it?
There's plenty of ways to answer this. The trialist would say, well, we're not there yet. The reason the BHF Protect study in the UK has 7,000 patients is because it needs 7,000 patients to actually make the point. I think they were just underpowered, which sounds crazy for 3,000, but that's just what it is. And the reason for that may be that they did not use, you know, I've got a long history. I dealt with cerebral embolic protection for a long time. We did all the studies with the other device, and we used neurologists and MRI, where you detect, in the MRI, in 90% you detect strokes, right? And if a neurologist looks at it, you have 6-7% strokes. But if you just take the ones where they stop speaking or they can't move their legs or their limbs, then it's down to 3 or 2%, right? So it may well be that there is protection, even clinical, but they haven't looked hard enough because they wanted a pragmatic trial. I believe with the 7,000 of BHF Protect, which will be out next year, maybe the year after, we've got 10,000 patients. We're aligned, it's all synchronized, the database is identical, so we can just merge them and then we'll have the answer.
So if you had to select a patient after this trial to protect, or to use a protect device, which patient?
So we're now in a lucky situation that we want to enroll everybody at BART. So we do 500 TAVIs, we try to enroll everybody and they get it or they don't. If we had to choose, we're in a hard place because there is no patient group that has so far qualified as being at particularly high risk. We think that patients with previous stroke and patients where we do a valve-in-valve have a particularly high risk, and in those we would do it clinically.
Do you mind? Thank you.
So Andreas, you quoted my editorial after Simplicity 2, and in fact you forgot to tell that there was a question mark at the end of my editorial. So is it the dead knell? And if you read the paper, in fact I say there are too many flaws in the randomized Simplicity 2 trial to be the end of it. And I believe that I was right because Simplicity 3 has reopened the door. I agree with you, with many question marks still left. However, we have other smaller trials in patients with less severe hypertension against pure simple medical therapy, 1-2 drugs, beautifully showing that there is a reduction in blood pressure that is significant, not the 20 millimeters that we expected from the earlier registries, Simplicity, Australian, and so forth, but still highly significant. There are concomitant data from the balloon-based denervation, the Radiance device, that are equally positive. I think the system works, only you have to select the patient well. No systolic hypertension, no elderly patient, no super-resistant hypertension. It works especially in patients who do not take their therapy regularly.
I totally agree. I didn't mean to say renal denervation is not proven. Our own practice shows it does something in patients in controlled studies. We're not quite sure how to select, but we know who not to select. But those patients were in the Simplicity HDN3 trial as well, so it's no real wonder that it didn't show an overall super success at 6 months. Speaking to hypertension specialists, which I just happened to have done 2 days ago in London, they point out 2 things. A, NICE recommends it for specific population, so there is evidence behind it, and it will be used in practice. And the effect to be expected is the equivalent of 1 tablet. But we have seen patients, we've all seen patients with critical hypertension where this renal denervation led to an abolition of medication and dramatic improvements. We can just not predict who they will be.
Ahmed, you have a comment?
Yeah. Thank you, Andreas, for summarizing the interesting talk. I have 2 questions. One, universal big surprise. Universal big surprise, ultrasound-guided access doesn't work.
Yes.
Do you think it was the absence of micropunctures? Would that have changed the results?
You know, this is one of the things where we go ahead and say, you know, this is clear, you have to do ultrasound-guided puncture. We do it in structural all the time. We swear it has to be better. We try to teach it to our fellows. But then if you really look into your practice and look what the fellows are doing, even with ultrasound, they sometimes get it wrong, right? And even with the micropuncture, sometimes the micropuncture is the problem. You know, the wire going in the wrong places because they go to places where the other wire wouldn't go. So in practice, I've seen problems with ultrasound and with micropuncture. So you think, yeah, well, they might be right. It might not be much better than just putting 2 fingers in the right place and making sure you're in the right height and just go the old-fashioned way.
Interesting take. The second question, so with the data we're getting from, it's obviously revived BCIS was a big surprise again. Totally agree, we have absolutely no idea about treating patients with ischemic cardiomyopathy nowadays.
Yeah.
We sort of understand who to revascularize. I'm not mostly guided by symptoms, but why are we doing nuclear scans? Why are we doing perfusion MRs, CMRs? Why are we looking for ischemia if every single piece of evidence we have, either viability doesn't really make a difference, reversible ischemia, regardless of the burden of ischemia, doesn't make a difference? With the 10 million scans in the US.
I think that again, so the question is why do we do all these scans and why do we justify angioplasty by imaging, saying there is viable myocardium, hence there must be a positive effect of opening up a CTO, for example. Why do we wait for ischemia? I think generally these are all valid concepts, because you wouldn't open up an artery if there is only scar. And I would still stand by that, right? And you wouldn't leave alone a proximal LAD lesion if there is, 30% of the myocardium getting ischemic on exertion. Even if the patient doesn't notice it too much, you would not leave that alone, because you know it's not the right thing. I believe some problem in these trials is that these obvious patients in many centers don't get randomized.
Thank you.
Thank you very much.